we're live. So once we are now we're already live, so you can start at any time.
Okay.
Whenever you're ready, just start. It's already.
Can we start? Good afternoon, everyone. So today here we are from Emirate Diabetes and Endocrine Congress. My name is Dr. Nada bin Hariz. I'm consultant endocrinology from Tawam Hospital and Sheikh Tahnoun Medical City in Al Ain City. And today we have Professor. Do you want to introduce yourself?
Yeah, hello, good afternoon. And it's nice to be invited here. And it's a pleasure also now that we could maybe discuss some aspects you are interested in.
Yeah. So I think the most important field maybe now is diabetes in older group. So it's one of the most clinical complex and it's rapidly evolving area in diabetes care. So I think that's put us or challenge us to think more to the rather than a numbers, but patient safety and his quality of life. So in that aspect, maybe let me to start and ask, why should treatment goals change with age?
Yeah, I think that's a very important question. How do we adjust goals with elderly populations? And I think the question is, should we deal with them differently? That was the title of my lecture. And to be honest, I said, no, we should not treat them differently, but we should treat them more cautiously and also very individualized. I'll give you an example. I mean, we know people in their 70s, maybe 75, still playing tennis, going to the gym, are very fit, no illness, but just type 2 diabetes. So I think we both would treat him or her like a person of the 40s or 50s. So he should get every treatment and all strict, let's say, goals. But on the other hand, and that makes it so interesting, we have an elderly person of also 75, and he is she's very frail. She has already 2 myocardial infarctions, 2 strokes, cannot move properly. So the target, the glycemic target, would be completely different. So the goal would be here to prevent her or him to go to hospital and just to lower the symptoms of hyperglycemia.
Okay, so that, Prof, maybe your main point is that we need to avoid hypoglycemia.
Yeah.
So how hypoglycemia can influence our management or how to prevent hypoglycemia risk?
Yes, I think it is, especially for the treatment of the elderly, it is a very important let's say, goal to prevent hypoglycemia. So first, of course, we have to do the differential treatment and see what are the drugs who do not produce hypoglycemia. And we all know them. I mean, it's metformin that never produces real hypoglycemia. SGLT2 inhibitors do not. And GLP-1 does not. The only exception is if you combine it with insulin or with sulfonylurea, then it could happen, but otherwise not. So take one of these drugs in order to avoid hypoglycemia. And then it's also a matter of instruction to the patient. He or she should really adjust the diet to that goal. And especially the very old patients, there it should be really the prime dogma not to induce hypoglycemia. If we, for some reason, have to put these patients on insulin, we should ask for a CGM in order to monitor and then also to place warnings against hypoglycemia.
So if this case or this patient being over-treated, so what the main dangers which we create in these patients?
Yeah, I think the main danger is if you put patients like this on sulfonylurea plus insulin. I think that's an absolute no-go. because then you have hypoglycemia from two sides. So I would skip completely the sulfonylurea. And the insulin treatment, the older the person is and the more fragile, I think the more you should really make the insulin treatment very easy. So prefer long-acting insulin given once a day. Do not prefer a very intensified regimen, because that, if it's necessary, okay, but normally this will not work in these patients. And most often you should really struggle for a CGM, because that provides some protection for the patient against hypoglycemia.
As you mentioned in the beginning, like you still see like a lot of patients, maybe at the age of 80 or whatever age it's, but still functioning, driving, and they are playing tennis, while other group maybe they are bedbound or on wheelchairs, or so completely different aspects. So how the functional status of those age group can guide our managements and how we can do that?
Yeah, I think, as you said, I mean, it's a very heterogeneous group, from an 80-year-old person doing everything what we are doing, and an 80, and the other one is laying in the bed and have severe illnesses. So this means the concept of individualization. So you have to categorize the patient and say, okay, this is the totally fit old person, but she or he gets all the treatment and all the goals like a 40-year-old person. And the other one is a severely ill patient where we really would like him or her to stay at home, not to go to the hospital for complications, and so we adjust the treatment exactly to that goal. To, let's say, have an HbA1c of 8.5 or something in that latter group, and say, okay, that's fine. If the blood glucose does not go up higher than 250 or 300, that's fine for you. But for the other one, we would really place a very strict goal, and also would try to enable him or her to lose weight in order to even be more fit for the time to come.
Yeah, maybe you answered already my next question, which when we think about prescriptions for this, or prescribe the medication for these patients, because to avoid polypharmacy and the burden of over treatments.
I think the patient with 80 and having 2 strokes already and 2 myocardial infarctions and is also not able to move, I think here I would really bring down the medication. You can even discuss whether a statin is still really functioning in that patient. If he tolerates it and he takes it, okay. But blood pressure control should be also in the range that the patient is not too low with his blood pressure. That would then cause maybe falling him down in the bathroom because he has a blood level, the pressure level of below 100. So relieve hypertensive treatment, relieve also a little bit statin treatment, and see what happens. But the other one, I think there I would go with full medication.
Okay, excellent. So maybe also we'd like to know from your experience how shared decision makings can be implemented, like in those type of populations.
Yes, I think it is, as you said, very important that the patient himself, herself, actively participates in this decision-making progress. For the fit person of 70, I think he can do it on his own. I think he may be still in business. He does his business decisions, so he should do also his decisions how to manage his health. But the other one maybe needs the advice of the family. So I would really include the closest family members in order to investigate what is the will of the patient. I mean, we have to envisage also that latter person may have cognitive impairment. So I would do a geriatric assessment and then decide together with the family what would be the best decision for him, what would be his wish to manage his health.
So I think it's mainly the role of caregiver to do more for this in this aspect about the medications and or what do you think? The role of caregiver themselves and those type of patients.
I think it should be a whole concept.
Okay.
Involving medication, whether polymedication is still manageable for the younger, more fitter person, or if it is very dangerous for the other one. And then, of course, diet is very important. In my lecture, I spoke about sarcopenia. That means that all of us, I mean, you are too young for that, but in my age, we are losing 1% of our muscle mass per year if we do not do something against it. And so, even for the very old person, it is crucial that she or he does some kind of resistance training. That means some kind of age-adjusted circle training, something that builds up muscles. And this concept has to come together with high-protein diet. So we should convince the person or the family that he should take 1.5 gram protein per kilogram of body weight. And that's a lot. So you have to think about it. To implement soya maybe and other things, also vegetables with high proteins. And if he combines that with some kind of age-adjusted weight training, he can really fight this muscle loss and stop sarcopenia. And this is a very important thing.
Yeah, thank you to address that. Yes, exactly. So high protein diet, for example, in context of patient with kidney disease, in context of patient who have already established comorbidities, how you will adjust the target of those special kind patients with comorbidities?
Yeah, I think you have to really make the whole picture. So with all kind of comorbidities. I do not see very many contraindications against high protein, at least not in this range up to 1.5. Of course, the nephrologist always telling us if you take too much of protein, you might worsen the CKD. But I think this is more a problem of even higher protein diets. So up to 1.5, and if you combine it with exercise, that would mean that the muscle will be built up, and the muscle takes the protein and the amino acids in order to build up the muscle mass. And so I don't see any contraindication, severe contraindication against that concept. But it is only really effective if you combine it with this kind of resistance training. And I think we in medicine forgot about that for some decades. Now when with sports medicine and all newer concepts coming up, so we realize that fighting against sarcopenia is very, very important for everybody.
Okay, excellent. So we are, as a physician, at the end, sometimes we are focusing on biochemical outcome. So how you think, like, what the outcome which be more in this age group, like, which we need to look for rather than biochemical outcome?
Yeah, it's a very important question. I think biochemical outcome as a prime outcome becomes less and less important with increasing age. I think quality of life is a prime parameter, so that the person who has a limited time of life expectancy should have the best possible quality of life. And that means mobility, means nutrition, not over-nutrition, but also keeping the weight if it's normal, or maybe do a little bit of weight decrease, and keep the person mobile. I think that is very important. Even in the very old, you can, and that has been shown in studies, that you introduce some kind of movement, of exercise, of physical activity. It increases the quality of life and increases the long-term outcome. So all this is more important than the figure of HbA1c.
Yeah. So Like prioritize the quality of life on those patient or age group is very important, as you highlighted already here. And do you think we can do something different in our maybe day to day? Do you want to add any message other than at the end of our talk?
I think what you and myself also is already doing is, I think in this more problematic group of patients, we are less interested in HbA1c. I mean, we were very interested 10 years ago.
Yeah.
That was the
Definitely.
focus, and that was, this is 0.6 less, and that's fine. Now I think we moved more towards the whole picture. And that means if the patient reports that he now lost 2 kilograms or 3 kilograms, and that enabled him to walk more in the living room and going around, and he even could manage maybe the first 10 steps up to the first floor. That is more important. And then we say, okay, this is a great success. Go on and move on that way, and that will give you the quality of life we can expect at this stage of your life.
Yeah, that's very important. Thank you very much again for this nice opportunity. Maybe very important message that we still need to, in all the area, we need to move away from focusing on number, and we need to focus more on patient quality of life, functionalities, and safety. And very important message about high protein diets and exercise, resistance exercise that will keep the patient in safe area. So thank you a lot, Professor, for you to be with us here in Emirate Diabetes Endocrine Congress. We are pleasure to have you today. Thank you.
Thank you very much for the nice discussion,
you.
and all the best
Thank
here
you.
for your efforts.
Thank you.